Lancet University Oslo Commission, Global Governance for Health, and which has come up with a fascinating report, very comprehensive report in 2013, I think, yeah. And she was also on the national level committee, which is a high-level expert universal health coverage, a report which was much discussed and debated in the Indian context. And so she was also on that committee representing the whole sector. So she's going to share some of her work today, which is a lot of this happening in the state of Uttar Pradesh, and we'll get to hear some of that. Thank you.
Thank you very much, Arima, and very good afternoon to all of you. I'm really grateful for Arima's persistence in putting together this conversation, and I'm really looking to share our experiences and hear from you. I actually rejected university life 30 years ago. Everyone thought I'd definitely go on the academic path because I was a double gold medalist. It was assumed that I'd do a maternal health today. And as she mentioned, I'm part of an organization called SAHAYOG that I was part of setting up. And over the last 15 years, SAHAYOG has really focused a lot of its attention on maternal mortality in Uttar Pradesh. Uttar Pradesh is actually among the 7 Indian states that, and Uttar Pradesh has the largest share. And these Indian states make up about 12% of the global burden of maternal mortality. So let me just start by giving the title of my presentation, which is Global Knowledge, Local Insights, Contests Around Maternal Health in India. And I will first start by talking about the local insights, and then we'll move into analyzing the role played by global knowledge in shaping the reality. So just let me take you back a few years to October 2008, pretty close to today's date. To Varanasi. I think many of you know about this place, and this is a village and a forest near it, and we have a bicycle, and there is a 26-year-old pregnant Dalit woman, I'll call her R, who is seated on the back of the bicycle, and she's trying to manage her labor pains as her husband takes her to the nearest health center 17 kilometers away. And they are really trying to get there on time. The last time she went through childbirth, the government hospital referred her out, and then she finally had to go to a private hospital, which incurred a lot of debt for their extremely marginal family. And this one now, they have registered the pregnancy. The health worker has told them that the government is encouraging everyone to come into hospital. They're getting there on time. They know there's going to be money. By 2 o'clock in the afternoon, they're at the hospital. There is no doctor. And there are only nurses. The nurses take her in, examine her, and then give a little slip to the husband saying you have to go buy 3 injections, 3 bottles of glucose, etc. And the husband has only carried 300 rupees because he thought, you know, they are actually going to be supported for this childbirth. So anyway, he finishes off all the money, and then he waits outside, and the evening passes and it's night, and at 11 o'clock the A&M comes out and tells the husband that he has to go and get some more glucose. And you know, it's a complicated case, and you know, things are not going well. So he has no more money, so he gets on his bicycle, he goes back 17 kilometers to the village, he spends the night looking for money, he raises a loan of 9,000 by mortgaging everything they have, and then he comes back to take care of his wife. It's 6 o'clock in the morning when he enters the hospital compound after another bicycle ride of 17 kilometers through the forest, and he finds that the hospital is deserted. There are no staff to be seen. In the middle of the yard is something covered with a white sheet. And he stands there trying to understand what is under that sheet. He tries to sit down next to the body to protest, but after a while somebody comes with a piece of paper and tries to get him to sign it with no explanation. He does not want to sign it. And then as it gets on to midday, his family members come and tell him that we should take the body now for cremation. So where is this story coming from? This story of the tragic death of R is a part of a collection that for the last 15 years has been put together to show how poor rural women actually die maternal deaths in the state of Uttar Pradesh. And this is being put together by a completely outraged group of civil society organizations, of which we are also a part, which is called the Health Watch Forum in Uttar Pradesh. We highlighted many of such cases in 2001 and then continued to document more cases in 2002, 2003, and then came back to the government, the media, the political parties to say that maternal death is actually a violation of women's constitutional rights to survive pregnancy and childbirth, and the state is accountable. It led to absolutely nothing. In 2004, 2005, this group worked on a case of a pregnant Dalit woman who was pushed out of the hospital while in labor, and she gave birth outside the gates of the hospital where the baby died. And the Health Watch group worked very closely with journalists for 1 year trying to ensure justice for this woman, and to really no avail. In 2006, this group was campaigning once again with policy actors, and in the course of this, a group of 200 women leaders from rural areas decided to form a grassroots organization of those who are the real users of the health services rather than NGOs. So this women's organization, which is called the Mahila Swasthya Adhikar Manch, which means Women's Health Rights Forum, we call it MSAM for short. It was set up not coincidentally, just about the time when the National Rural Health Mission was taking off, and I'm assuming many of you in this room are familiar with the National Rural Health Mission, which was this large program which actually had a lot of focus on maternal health. So then in 2011, as you know, that the government ensured that all maternal services and newborn services must be free. They brought in this complete coverage through the Janani Shishu Suraksha Karyakram, and that meant that women had to pay absolutely nothing. Nothing for hospital costs, nothing for transportation, treatment, medicines, nothing at all. In the course of these years since 2006, the Mahila Swasthya Adhikar Manch has mobilized around 12,000 women who continue to monitor what are their entitlements within the National Rural Health Mission and to put pressure on the local and the state authorities for greater accountability and for improved quality of services. And until today, 15 years down the line, SAHAYOG and the other partners of the Health Watch Forum continue to document cases of maternal mortality. I mean, for example, in 2005 to 2007, we documented another 23 cases of maternal deaths and adverse outcomes, which were published in a report after NRHM to the government of India. But the government said, oh, health is, it's a state matter. We made the NRHM, but what happens when women die is really not our business. Then again, there were more cases coming up of women dying. In 2009, there was actually a public hearing that was organized in which this story, the one that I just told you, the testimony was presented, along with many other tragic stories of very young women dying at the ages of 22, 23, 25, and so on. So what did we, as a civil society group, learn from these stories? Well, we found that although we had been documenting cases before the NRHM, even after all of these, health sector reforms, the findings remain depressingly similar. And despite women doing what the government wanted them to do, which was to come into the hospitals, to register their pregnancies, to be there on time, etc., they continued to face humiliation, disempowerment, poor quality services, petty corruption, and sometimes just outright denial of care. And to be fair, the stories also show that the health system is in a shambles. It's in a completely dilapidated condition, it's underfunded, it's poorly governed, and it's probably quite similar to the health system used by poor people in other parts of the country. The stories tell us that doctors and those with skills are actually seeking better earnings away from these underserved areas. So who's left behind? It's those poorly trained staff who lack the competence and who therefore remain totally unsupervised in terms of what they're doing to the women that reach the institutions. So for us, the cases continue to raise the basic questions of institutional capacity and willingness to respond to poor women's increased demand for maternal health services. And what was really worrying is that there was no mechanism set up by the government to ensure some degree of accountability for what women received when they tried to access public services. And of course, as you know, the poor are shut out from participating in the management of their local health centers. Let's just look at the figures a little bit. What are these hospitals actually meant to handle? So, does anybody know how many pregnancies happen in India every year? Wild guess? Ballpark figure? Anybody? Give or take a few million? A crore births. Okay, that's a bit extreme. I'm going to say that's a bit extreme. Anybody else? Any other guesses? Sorry? 1 million. Lovely. It's 25 million childbirths every year. So there are more pregnancies. There are about 27 million pregnancies. And Uttar Pradesh, of course, has 4 to 5 million childbirths every year. So the facility level data of the government in 2007 said very clearly that the primary health centers and the community health centers in the public sector were completely under-equipped and understaffed to handle any kind of pregnancy complications or childbirth-related illnesses. So far, these had been handling about 25% of the childbirths, and it was 27% institutional delivery before the NRHM took off. And the rest of the women were at home. They were giving birth at home. But the policy prescription was that women should be given a cash incentive, and all of them, if not all 5 million, at least many thousands more should be brought into the hospitals. And because of the cash incentive, it kind of became the focus of what the government was actually tracking. It was the only thing that was being counted by the health department, and essential information about the quality of care and about the lives being saved or not saved was left out. The NRHM actually wanted to strengthen the health system. We cannot deny that. It was on the agenda, but unfortunately, that received far, far less attention than this business of counting the JSY. Now, to those of us in the civil society groups that had been working since 2000 and 2001, in the villages, it was absolutely apparent that loading this ill-equipped public health system with tens of thousands more pregnant women every year was not going to ensure that women's lives were saved. It's quite simple to guess that if a woman comes in a critical condition who actually needs the specialized care that a hospital can supposedly provide, in this stampede of cases, those critical cases are going to get ignored, and they might even be turned away. And who knows, they might be compelled to actually seek care in the private sector, even if they could not afford it. Right down to today, we continue to document those absolutely similar cases of women braving great odds to get into the hospitals, and with the same sequence of staff either demanding money, denying care, abuse and harassment, irrational medical practices, some of which actually border on quackery. And then in desperation, the families ricochet out into the private sector, and because they cannot get the kind of care that they need to save the lives of the women. What are the government's data actually telling us? So the data from the NRHM quite predictably says that this cash incentive approach has really succeeded. So compared to 41% of women in 2004 coming into hospitals during childbirth, right now 73% of those 25 million are actually giving birth in hospitals, according to the Registrar General. And it is undeniable that maternal deaths are decreasing in India. But the question is, why are they decreasing? There is something called a secular trend, which happens because women are having fewer pregnancies. And so, obviously, the possibility of maternal deaths is going down. Now, the JSY was actually meant to address the equity gap, ensure that the poor could also access life-saving care by coming into hospitals. But Randiver's paper in 2014, comparing the data from the last two rounds of survey from the Registrar General, finds that there is a far higher rate of maternal mortality among the poorest women, who are 4 times more likely to die as women in the richest quintile division. You might have looked at the National Sample Survey Organization data, the 71st round, and you might have seen the very shocking information that out-of-pocket expenses for families seeking maternal care has not reduced. And all these government JSSK schemes and JSY and so on, actually in rural areas a family spends an average of 5,544 rupees. I mean, the average in a public hospital is about 15 to 1,600, and in a private hospital it's about 14 to 15,000 that they spend. So this is average costs. Now, why am I giving you all these intensely local experiences, and why did I say I was going to talk about the global discourse? And I think there's a darker tale here, and it has implications that really resonate many thousands of miles away from the hospital where poor R met her untimely and preventable end. Globally, the issue of maternal mortality has been part of various international agreements and treaties, which India is also party to. I'm sure you all know about the Alma Ata Declaration in 78, the CEDAW Treaty on Women's Rights in 79, the Cairo Platform of Action, which was in the Conference on Population and Development in 94, and the Beijing Women's Conference Program of Action in 95. Now, all these global development goals before, in the 90s, were very aspirational and used the language of rights. But unfortunately, the Millennium Development Goals was a disappointingly minimal set of pragmatic targets. It included maternal mortality, and it did talk about women's development and empowerment, but actually in practice, it erased the language of rights, and in a sense, it eroded the identity of women as subject citizens who have rights. And this is an identity that feminists had through the 90s really fought hard to retain within the international treaties, conventions, and policies. But feminists have identified that the Bretton Woods institutions like the IMF and the World Bank have actually been part of moving the discourse of public policy, which is not as policies for citizens, but more as services for clients, for consumers. So thereby we are actually opening the way into the notion of health markets and how we can expand health markets. So maternal mortality reduction did gain prominence because of the MDGs, that's completely undeniable, but it did lead to a new form of vertical programming for reproductive health, which was not articulated in the way that the women's health movement had actually strongly influenced during the Cairo and Beijing discussions on comprehensive reproductive and sexual health and rights. Instead, now, the technical expertise of obstetricians and public health researchers was sought to redefine the problem of maternal mortality. And the complex chain of causes that actually leads up to the death of a woman got really narrowed down and defined by technical experts to just one problem of women not having trained professionals to oversee their childbirth. So there was a simplified indicator, which would be to track increased skilled attendance at childbirth. This was this MDG indicator I'm sure you're all aware of. Now, India, of course, has a disproportionate burden of the world's maternal mortality, and although for 10 years we have been intensely implementing policies to promote maternal health, many challenges remain. And one of them is this massive accountability deficit, which is not just in the public sector, but very much also in the private sector. Now, global guidance on a biomedical and technology-focused approach, which was buttressed by this demand-side financing, actually has not been able to address these complex issues. And we have unruly practices. We have an extremely recalcitrant mixed health system in which the public and the private seamlessly flow into each other. And given this, India really provides a case study of how an expert-driven health policy, which defined the needs and which kind of designed the solutions for a very homogenized idea of the poor rural woman. But it failed to recognize the diverse lived realities of women as gendered citizens and whose relationship to health institutions is actually mediated through their class and social identity. So the problem was diagnosed as women failing to access skilled attendance at childbirth because they don't come in to the hospital during labor. So the policy solution, you motivate women, you give them this conditional cash transfer, and the assumption was that if you get them to health facilities, that's the only place they can get skilled attendance. And this skilled attendance definitely is going to save their lives. So definitely we are going to reduce maternal mortality. Do you agree? Do you agree? Silence. So we are thinking, and significant budget allocations were made. Again, it drew upon the international expertise of development economics and decided that a demand-side stimulus was needed, and that was the conditional cash transfer. And the health impact would quite simply be measured by just counting how many women got this cash transfer. Definitely, all of those women must have had hospital deliveries, and therefore, all of them must have had safe deliveries. So somehow, in the urge to measure up to this very narrow MDG indicator, the policy attention was deflected away from the original goal, which was actually to address the problem of maternal mortality, and the inconvenient truths about the health system was brushed under the carpet. As I said, there are 25 million women who need this kind of care, and there are not enough doctors in our rural health centers. Nurses are not skilled in childbirth, definitely not in managing any kind of complications. There are not enough medicines, equipment. Health centers are not accessible to a significant proportion of the population. All this is not my data. It was government data which was available when all these programs were being designed. But the inflexible policy solution ignored the fact that there was an absence of enabling conditions in many parts of the country, where there are no roads, where there is inadequate public transportation, people live in remote areas, in riverine, coastal, mountain, desert areas, and so on. And there was a deafening silence in the policy discourse about the reality of those millions of women who do not reach hospitals and therefore give birth at home. Nothing was done to make life safer for them in terms of childbirth, nothing in terms of community-based services, and of course the TBA program, the traditional birth attendant program, had been completely discredited because internationally there was suddenly now disapproval of what the WHO had promoted for 15 years was suddenly, no, this is all wrong, we must get women to hospitals, TBAs must go down the drain. So for women in urban slums, in poor hamlets, in remote villages not connected by roads, there was no alternative. Either you reached a hospital or you stayed in an unsafe childbirth at home. It is incredible that the policymakers who designed this did not anticipate that facilities would get overcrowded and that the inadequate numbers of poorly trained and poorly equipped staff would actually turn away women who were sort of seen as being, coming too early or coming too late, or seems like you have a complication, you should just go away from here. The single point intervention also ignored the fact that it's not just during childbirth that women die. Women die during pregnancies, during unsafe abortions, and many, many women die after childbirth, 10 to 40 days after childbirth. This is completely left out in the policy calculation. And there was, of course, no consideration about the fact that women are anemic, malnourished, etc. There are infectious diseases like TB, malaria. That was just not part of the policy calculation. So here we have an example of an issue which affects only women give birth to children. Disproportionately, the problem of maternal mortality affects poor women, women from marginalized groups. But the problem was entirely constructed by expert voices. And these defined the woman, the poor woman, as the problem category that needed an intervention when she gives birth, because that's when most deaths occur. And the alternative way of looking at it, in which the problem may be defined as inadequate health facilities and a poorly functioning health system, this was not actually part of the policy map. The established international knowledge around the issue very clearly described it as a problem of the women. They've been giving birth at home. They're actually poor. They need money. They're too ignorant. They're too slow to access, modern facilities like coming into hospitals. And so they need to be kind of given this push by giving this conditional cash transfer. So the technical expertise of international organizations, which is dominated by obstetricians, economists, and public health researchers, dictated the policy solution to the problem. And the evidence-based assumption was that women should get to an obstetrician in time and none of them will need to die. Now, this sounds very rational, and so it's very easy to say that this must be the truth. And so women could be persuaded to see themselves as fault and themselves as being irrational. So the invocation of this, global health knowledge and this medical expertise, it lent a lot of substance to this narrative. And so it was very difficult to shift the locus of the problem into the dysfunctional health services or the poor treatment of the staff towards the women. So the whole emphasis was that women are the ones who are making the mistake. Now, the national government actually furthered this global health perspective, and it located the problem there rather than looking at its own crumbling health system, which was already plagued by underinvestment and poor management. And so the woman was the problem category, and she was offered this potentially life-saving option. If you can meet this good behavior standard, which is you have to reach the hospital in time, then we can actually give you a cash reward and then your life could be saved. But if you fail to conform to this carefully defined standard of what is good behavior for any reason, we as the state refuse to take responsibility for the fact that you die. So if she chose not to go, or if she was not able to go, in fact, if there are no roads from her village, if she's been turned away from the health center, if she could not pay the bribe and therefore had to leave the hospital, if she just desperately went from one health center to another to look for this skilled attendant who could manage her childbirth, and if she finally reached a tertiary center after a long drawn struggle for transportation, for resources, for medicines, it was definitely her fault for coming too late. And so the government was not making itself answerable in any way for the safe outcome of this woman who undergoes pregnancy. And basically the entitlement is just that cash reward if you meet the good behavior standard. So in this way, the state erases the language of rights and accountability and undermines its own constitutional obligations for ensuring the health and the lives saved of these pregnant women. So this entire construction actually deflects attention from the systemic issues about the lower health budgets and the unethical practices of the health system and the unregulated profit-seeking health sector. And the rational expert logic makes that very messy aspects of women's reality completely invisible. Now, the contestation from the feminist and rights-based civil society groups has been precisely to bring out these realities. We are raising the question, which women are dying? Which are the social groups that are falling through the cracks of this carefully constructed policy? And poor women in India die because they are Dalits, because they are minorities, because they are slum dwellers, they are indigenous tribes living in remote areas where there are no roads. Women cannot take the decisions about when they should marry, whether they can have protected sex, whether they even want to keep their pregnancy, and they have to just keep on fulfilling their social obligations. Poor women can die because they are anemic, they're emaciated, they're suffering from untreated tuberculosis or malaria. They die also because they do not control the money in the household. They don't own vehicles which they can summon to take them into hospital. Women also die because hospitals treat them badly. They abuse and harass them for money. They even turn them away. And also poor women die because the doctors and the nurses and the medicines which are needed to save their lives are only available where the middle classes or the richer classes live, which is in cities and frequently in private hospitals, not in the poor public system, which is meant for the poor. The providers who actually stay and work in these remote areas, they are often underworked, overcompensated, and are quite likely to be underskilled. So poor women also die because policymakers agree to starve the health system of resources and permit it to become dysfunctional, and they neglect to call for accountability for their deaths. So to conclude, pregnancy and childbirth, for all of you who are sitting in this room, are definitely occasions for celebration. We belong to the middle classes. But for the poor in India, they signify terrifying possibilities of trauma, disability, death, and intergenerational debt. Today, women continue to die in staggering numbers in the 21st century, not because we don't know how to manage a safe childbirth or it's rocket science to treat complications of pregnant women. It's not because treatment is unaffordable, like some rare form of cancer. And it's not because across the country we do not have enough doctors and nurses. We do know how to save their lives. It's really a question of prioritizing, of effectively deploying our resources and putting in place mechanisms to deal with the accountability deficit. I would therefore argue, in conclusion, that there is a need to retain and to foster the critical approach of social movements to examine the ground realities where laws and policies operate through the experience of the actual users, and to feed that research back into policy forums so that we can prevent the governmental policy juggernaut from defining the problem in other ways that are not linked to women's realities. In fact, the presence of SAHAYOG in certain policy spaces, as Arima pointed out, has actually provided us an opportunity to present these experiences of women as gendered subjects, which really questions the definition of the problem of maternal mortality. So in partnership with our other colleagues and organizations in the Health Watch Forum in Uttar Pradesh, we've been building up a profile as a feminist organization using rights-based approaches, questioning the state policies that have violated women's rights and have failed to translate into an improved quality of life for the poor. We are a formally registered organization. We receive funding to carry out development activities. But nonetheless, we have adopted several strategies of social movements, and we work in close alliance with them in order to realize our mission. And so we see ourselves as basically an oppositional form of civil society. And we have with us many fellow travelers from the realms of research and academics, also from many other disciplines, law, economics, budgets, and so on. And all of us are working together, but maintaining a strongly critical stance. And we have carved out an identity which is distinct from most development organizations that work on the broad umbrella of civil society. So I just want to leave you all with a question, The whole global development expertise which was generated around the MDG indicators and targets have strongly influenced policymaking in India to bring down maternal deaths. But we as civil society has been strongly contesting them and advocating for other policy approaches which are more comprehensive and which are in keeping with India's human rights obligations as well as all the treaties that it has become signatory to. Our local insights, and here I'm speaking not just of SAHAYOG and Health Watch Forum, but many other civil society formations across the country, our local insights continue to provide a contrary picture to the very globally acclaimed results of the NRHM's approach. And now we are actually getting more scholarly analyses of maternal health data, which is substantiating this picture that we are putting up. So the question that I leave you with, and I really hope to hear your thoughts, is should policymakers automatically accord greater legitimacy to global knowledge, which is often derived from context-neutral meta-analyses across multiple country settings? how can we overcome the comparative neglect of context-specific analyses which are enriched by a more grounded perspective as civil society organizations can provide? Thank you.
Thanks, Jashodhara, for the very nuanced presentation on drawing our attention to the troubling local realities in rural UP. But the realities, I think, finds resonance with many other parts of India as well. Leaving us with the largest set of questions as to who is ultimately responsible for these deaths. And it is troubling because I think there is enough evidence to show that maternal deaths are completely preventable. And yet, women continue to die. So who is responsible and who is accountable? And to what extent actually the policies which are based on some kind of resources and knowledge, as Jashodhara says, coming from somewhere else, actually can accommodate, incorporate language of rights in its larger engagement with the state and the citizen. So, well, now it's open for discussion. Yeah, sure.
Extremely inspirational talk. What can you do you have?
So I just wanted to ask a question about the incentivized delivery, institutional delivery, a model that is now being adopted in Kenya as well. So last month's caravan actually carried a story about this. And I'm wondering what your thoughts are about it, because they are talking about this as being an extremely successful model in India, and therefore they are taking it to poor villages of Kenya and trying to do the same thing.
We'll take a few more questions and we'll answer all of them. Yeah? We'll take this. Yeah. It's clear.
So, ma'am, my question was related to access to blood. So, how does it affect, like, what kind of effect it has on maternal deaths? And if so, what can be done? Because blood is a little different from medicines. It's something that has life and all other issues associated. So, that'll help.
Thank you so much for the wonderful talk. So, you said that you were working with the rural UP population in your field. So, how would you like to respond on the intersectionality of the religion in that particular state, where there's a huge section of Muslim women that also come in the rural poor? So, does that factor of religion influence the decision making in certain senses regarding the access or whatever?
Hello, ma'am. This is regarding the maternal mortality. So, which age group of women affected the most due to that mortality? And second question is about Mahila Swastha Adhikar Manch. So, this is actually mobilizing the women. This Manch is mobilizing the women. So, which age group of the women is focused in mobilizing by this Mahila Swastha?
I just wanted to know where the Anganwadis come in the prevention of maternal mortalities, because even though they are targeted towards children development, they do have programs where they're supposed to educate pregnant women, and they give them iron folic tablets and supplementary nutrition and all those things. So I just want to know how ICDS and Anganwadi has played a role in reducing maternal mortality ratio.
So, thank you very much for all your questions. I'll take the simplest one first about the age group of women who die. Pregnancies happen very early in India. And inevitably, it's the 15 to 24 age group which has very high rate of maternal mortality. Very, very sad, but that's what happens. But that's also inevitable because pregnancies in India happen early, and because of our sterilization program, they end early. So this is the age group when women become pregnant. You can increase it to 35 at the most, but really it is 15 to 24. And you can actually look at the Registrar General's data because that has an age-wise disaggregation. So it will tell you exactly. And about the Mahila Swasthya Adhikar Manch, somebody asked about how old they are. Well, the funny thing is when we started the Manch, a very large proportion of women were those who were not going to have children after this. They were older women. And that's because it's easier always in a very patriarchal area like Uttar Pradesh to bring out older women for mobilizational activities. But gradually now, and because we have also sort of been consciously pushing for it, the leadership is now including younger women. It was earlier the older women whose daughters-in-law or daughters were going to be, pregnant and have children. But now it is younger women. So broadly, it's a very sort of large age group in the sense it could start from maybe the 20s and go up until the 50s. Okay, those were the two simple questions. Let's go to the others. The tough one. The model is going into other countries. Well, I'm really sad to say, Sriparna, no? The model has actually been implemented already in the 4 countries of South Asia. All of them have had this push to bring women into institutions, even though there are no institutions, for instance, in a place like Nepal. And in Bangladesh, maternal mortality has come down even with home childbirth, but even so, the official policy is to push women into institutions. And across the board, we find that demand-side financing is gaining a lot of traction as an appropriate method, whereas our civil society explorations indicate that this is absolutely the wrong way to go. And you should invest not in this, but in strengthening the health system. The budget analysis that we have been doing as part of our national collective has shown that health budgets have actually suffered because of the thousands of crores that have been given as JSY money. And as you can make out from the NSSO data, the JSY money didn't actually reach the people at all. They are spending many times more in accessing healthcare. So the health budget, which should have gone into strengthening primary care, into ensuring that emergency care is available for women who have complications and could die, those budgets were never given, and they were all diverted into JSY. So it's actually been killing. This demand-side financing policy has actually killed women, and it's crucial that the research community should also point this out sooner rather than later. And it's not just Africa, by the way, it's also Latin America where this has been pushed through. So it's just across the board in the developing world, this is being seen as the appropriate formula to bring down maternal mortality. Access to blood. That's a very critical question. A lot of our documentation in tribal areas, for example, in Madhya Pradesh, in Jharkhand, Chhattisgarh, etc., Odisha, has shown that women are presenting with a hemoglobin of 3 during childbirth. So imagine somebody who starts bleeding who has a hemoglobin of 3. There is absolutely no way you can save her without a blood transfusion or a packed cell transfusion or whatever it is they do. The sad thing is that in India, the whole question of access to blood has also got implicated with the question of HIV-infected blood. And so right now, because of the NACO guidelines, blood is not freely available. Very, very few hospitals run blood banks. Very, very few have blood storage units, but mostly they don't store. So any woman who has a hemorrhage is immediately referred out to the blood bank or to the nearest medical college hospital, and it's usually more than a 4-hour journey, and lives are lost entirely because of this policy. Currently, we are trying to put together a public interest litigation on this to say that at least for emergency situations, unbanked direct blood transfusion should be available. But it's it's crazy how it happens. I'll just give you a very small example. In the district of Godda, there have been maternal deaths documented by one activist for the last 3 years. He's also got an article in the EPW. You can look at it. It's called Stairway to Death. And he's been bringing out, I think from like 2010, that women are dying because of the lack of blood transfusion facilities. So we did a fact finding in 2013, and we went and met the state mission director. We had meetings after meetings telling them that this is a tribal area. Women are coming with very low hemoglobin. It urgently needs blood. You know, even the district hospital doesn't have blood transfusion facilities. So they said, oh, we'll get it done. So the next time when we went back after 1 year, they said, yeah, it's got done. I said, no, it hasn't got done. Women are still dying because we're still getting cases of women dying from bleeding. So then he makes me call up the medical officer who says, हाँ सर वो बस अभी start होने वाला है. असल में क्या है कि we don't have a generator, so you know without backup, electricity is so bad. What's the point of keeping blood? It'll all go bad. So the generator has gone for repairs. In a few days it'll come. So that was 1 year since we had our meeting. So this is 2014. 2015, again, we have cases after cases of women dying. Even today, the blood transfusion facility is not working. It's just incredible. And there is nothing at the district hospital. There is one PHC which has, a CHC which has blood transfusion. Somehow, I mean, this is a district that does maternal death audits. This is a district that has been written up in the EPW. You know, everybody knows why these women are dying. My question is, why is it not a priority to save their lives? Which is why I'm talking about pregnant women as the gendered subject of rights. They are not clients, they are not beneficiaries to come and use the JSY conditional cash transfer. There is no accountability to saving their lives. And of course, if they are tribal and poor and illiterate and dirty and smelly and don't speak your language, definitely their lives are not worth saving. We need to understand these realities, you know, when we talk about these policies. It is their class, caste, and other identities that mediate what they will receive from the state and the functionaries of the state. To come back to the question about the religious minorities and Muslims, we have worked with Muslims in Western Uttar Pradesh. We don't actually hold with the stereotype of Muslims not wanting to access healthcare. And I think you all must have seen that the NFHS data is also showing it is not that Muslims have lower access to institutions. It's very interesting. Muslims use private health institutions. They don't go to the public health system. Can anyone guess why? Why would poor Muslim families be willing to spend money and go to a private hospital? It's discrimination. They are treated badly. They are given, you know, what we call sort of religion-related abuses. And so they don't want to go. And the data shows this, that they are not, it's not that they're ignorant or they have, you know, religious problems about accessing healthcare. No. There are these similar myths propagated about Muslim women not accessing tubectomies, you know. But you have to see how they are treated. And I mean, I could just give you a quick horror story from Uttar Pradesh again. There was a Muslim woman who had 8 pregnancies already, and during her 9th pregnancy, she was sick. She was the wife of a rickshaw puller. He took her straight to the district hospital. He thought she would get the best treatment there. There's a woman doctor, you know. He was a very caring husband. He decided she needed the best treatment during her pregnancy. And guess what the woman doctor did? Under pretext of doing an antenatal checkup, she stuffed her sari into her mouth. She performed a forcible abortion and a forcible tubectomy without anesthesia. I have that woman on video. You can go to my website and hear her testimony. So it's not about whether the minorities are reluctant to access the health system. It's also about how the health system treats them. And when we had gone for the fact finding, this woman doctor, of course, she had absconded by then. So we met some of her colleagues. And we told him that, you know, you must have heard about this incident. Paper mein bahut aaya tha. And he said, हाँ, क्या आतंकवादी और चोर पैदा कराना है क्या? Everybody understands Hindi? Yeah. Means that do you want these women to give birth to more terrorists and thieves? So she did the right thing, you know. This woman was sick for 2 years after that. They spent unimaginable sums of money getting treatment, not from that district, they had to go to Allahabad and so on and so forth. We've just sort of completed her treatment a few months ago, but it is a devastating story of this family's got wiped out economically because of what this doctor did to this woman. ICDS, your question. Yes, the ICDS system is meant to actually promote women's health. It is meant to provide maternal nutrition, both in pregnancy and after childbirth, and also, of course, give all these immunizations and things. And there is a whole setup by which the ICDS system is meant to collaborate with the health system through an occasion which is called the Village Health Nutrition Day. And we've been studying this in 4 states now as part of some other work on maternal mortality. And it's interesting how this day actually gets implemented. It's interesting, Odisha is actually very, very strong in its implementation of this Village Health and Nutrition Day, also because of their mamata and their focus on maternal nutrition. They've taken that up as a real crusade. But elsewhere, it's just not working, and departmental convergence is a huge crisis. We have been fortunate because these MSAM women that we work with, we have also provided them with information not just about health entitlements, but also about nutrition and food security entitlements. So they do a lot of monitoring of their ICDS centers, get them to work, get these VHNDs to happen, control the PDS shops which are, stealing the food grains and so on. So it's possible to kind of make it work, but you need a very dynamic community push to make this, convergence actually happen. Okay, the last question about men. Of course, we have to work with men, we have to work with families. But the funny thing is, in my 15 years of work in Uttar Pradesh, this is totally anecdotal and coincidental, you can completely dismiss what I'm saying. I never found a family, no matter how poor, no matter how illiterate, no matter how remote they were from the health centers, that did not try to save the life of their women. So I actually have a problem with this approach, which says, oh, these men, they're just waiting for this woman to die and they'll get another wife and all of that. This story that I told you about this man who came back, and he saw, can you imagine, what he did to get her care, to get that money for her, So it's not so simple that families don't care. Families do care. And I think the lower you go down the economic rung, families care more. I think it's as we move upwards that we find families really don't want daughters because daughters are seen as an expensive burden. In tribal areas, in our studies, we have found definitely there, it's not just the men. The entire community has an alienation with the formal health system. And there are many reasons for that. Like I mentioned with the issue of religious minorities, tribals have also been treated very badly by the health system, So there is a kind of overall belief that this formal health system is not for us. And if we go there, we'll just be, feeling really traumatized at the end of it. And so many cases, the women left the hospital, against medical advice. They just walked away from the hospital because they just felt that this is not a place which, is valuing our lives or our dignity. It's a huge question of dignity as well. And I think it's okay to say that, okay, let's educate the families and tell them to go to the hospitals. What are you doing to educate the hospitals? So I have a little bit of a disagreement with this approach which says, these community members, these men, these patriarchal families, they are also responsible for these women dying. Because I think there are other perspectives which we may be missing and which I think bear looking at. Okay, thanks.
Thanks, Jashodhara. That was an excellent talk. And I think it beautifully tied in all of the issues that we've been addressing in our various health courses for those of the audience that are part of our health and nutrition group. So that was really excellent. Couple of issues. One was, it appears that we've gone so far down this road already with the NRHM and the JSY and the incentivization of institutional delivery and so on. What do you think would be a good way of approaching this? Can we actually roll back some of this stuff, or can we at this point start thinking of a completely new way of framing this whole issue of maternal death, maternal mortality, and maternal safety, safe motherhood? And also, the other issue that I was thinking when we were talking about this model, so-called model, being exported to different countries and in Africa and Latin America and so on. In Latin America, if I recall, this Progressa program was so successful because they did not target only maternal death. I mean, it's a very broad-based program which looks at health for the entire family, looking at it in a very broad and multi-sectoral way, including nutrition, safe motherhood, child safety, and all of that as a package, education, other social sectors. And is that, I mean, rather than rejecting this model, would it help to actually broaden it, the scope of it, and look at it from a more larger social safety net perspective? And also your thoughts on infant mortality and under 5 mortality, because we focus a lot on maternal mortality, quite rightly, because it's really shameful that so many women should die in childbirth. But what happens subsequently is that there's multiple numbers of children who die for equally preventable reasons. And what can we look at this as interconnected issues?
Some really important points on accountability deficits. In your view and experience thus far, what are some of the mechanisms that can help reduce these deficits?
Great talk, Mr. It's always nice listening to you. I'm just again, I think it's following up on her thoughts. What are the solutions? That's great to present the problems, but we also need to think about solutions. In the past, many years, I've been also working in the field of maternal and mortality, and these questions always come up as to how to address what is that needs to be done. You raised 2 areas where you said demand side financing. I'm neither a big fan nor against it, because I think there are some merits to it. All demand side incentives have to be mapped and matched with supply side incentives. You cannot have one without the other. I think what perhaps went wrong with our program is that we only did the demand side financing, or the demand side incentives were provided, but we did not strengthen our supply side. So strengthening supply side is easy to say. We know we have lack of doctors, we know we don't have trained staff. So how do you fix it? So we have been also trying to fix it, not like we haven't, NRHM hasn't tried, others haven't tried. We have been trying to fix this problem for the last many years. One of the areas that recently that we've been thinking about and talking about is, can we train our nurses? Because most deliveries, not all deliveries in the public institutions are done by nurses. Can we train them better? Can we provide them with the skills? Because you cannot get medical doctors in the PA, it's not possible. They have tried various methods of giving them incentives, doesn't work. So asking a particular cadre to be present in a place where they don't want to be, could we train nurse practitioners who can provide the care and improve that, give them a little bit more freedom, a little bit more accountability, a little bit more choices, so they are trained well and they can perform. Again, thinking of solutions, what is it that we could do?
It was seamlessly flow into each other, and I didn't quite understand the context of that. And the other thing you mentioned, that the Millennium Development Goals had kind of erased the rights-based language that was going on while in the other conventions that you mentioned. So I just wanted to ask, as to what power did the MDGs really have to kind of erase the discourse that was going on before that was about rights?
Okay. Thanks, great questions. Everybody, for the model, I think a couple of you have raised that issue. What is the model? I mean, are we nihilistic, destroy everything and down with everything? No, I don't think that's the point. Here I must acknowledge that apart from Health Watch Forum, there's also a national collective that I'm part of, which is called the National Alliance on Maternal Health and Human Rights. What I'm saying now is actually part of the collective thinking of that group. So the National Alliance really feels that the government has to move into what we are calling second generation programming. You know, version 1.0 was get women into hospitals. But version 2.0 cannot be that. There are other issues that are coming out. And 10 years now, it's 10 years since 2005, we really need to think differently. So we are appreciative of a new policy document that came out about a year and a half ago called the Reproductive, Maternal, Newborn, Child Health, Adolescent Abortion Strategy, RMNCHAA. This actually does talk about some of these problems. It talks about, accountability, hard to reach areas, blah, blah, and, special mechanisms and so on. So our collective has really created a blueprint consisting of 4 points. And I want to just share that with you because we feel that if nothing else, I mean, okay, you cannot pick up and throw everything that has happened for the last 10 years. You cannot do that. It's happened. What can you do, to tinker with the system and ensure that more lives are not needlessly lost? One of the things we are saying is definitely focus on equity. The maternal mortality data in India is not disaggregated by social characteristic. All other data is. If any of you look at the DLHS and NFHS, you will see that it actually brings out social characteristic for all parameters, whereas the annual health survey and the coverage evaluation survey did not. And of course, the Registrar General's report does not talk about social characteristics, but we do have many more sophisticated mechanisms of collecting findings, and it's important to pick up which groups of women, which are those social groups which are falling through the cracks. And our examination until date definitely points out that it is tribal women. That is one major category. We also know from the DLHS and NFHS findings that poorer women, women with less education, women from the scheduled castes and tribes are less likely to access a lot of services. So there are kind of proxy indicators that show that equity is a major problem. And the Randive paper that I mentioned, 2014 paper, very clearly shows that equity is a huge thing. 4 times more poorer women die as compared to richer women. So we are asking the government to very clearly examine the equity parameters and try and focus attention where it's most needed. For instance, in tribal areas, you need a different approach. Business as usual will not work. As I just said, the tribal communities are completely alienated from this health system that treats them like dirt. So you have to have a different approach. Our second recommendation is about the private sector. The private sector is the elephant in the room. It's not that India doesn't have doctors. It's just that 90% of our doctors are in the private sector, and most of that is in urban areas, right? It's not that we don't have doctors, we don't have medical colleges and so on. We are not like that. So the problem is also that there is a completely unregulated private sector, and the point about the seamlessness of the two is that many of those who work in the public sector actually do not attend their duties. For instance, in the case of R, the doctor had left to attend to his own private clinic up there in the Kasbah. He was not there in this particular hospital. So there is that. Already there is a lot of public-private partnership in which many things have been contracted out to the private sector. All diagnostic equipment in all public hospitals is inevitably out of repair. And you must go out to the diagnostic shop very conveniently round the corner to get your blood test, your X-ray, your ultrasound, whatever it is you need. There is this seamlessness, Oh, this hasn't been repaired. Oh, that spare part has not come. Oh, the generator's not working, etc. But the private sector somehow is bouncing, shining, always in full repair, right? So there are many more examples like this, but that's how it is. Medical shops and so on. I mean, I could just go on and on about that. So the regulation of the private sector is the second key point, and the regulated utilization of the private sector to ensure provisioning of services in the public sector. I'm not going to go into a description of our HLEG report on the PHFI office, I'm sure has many copies of it, but the report that we did on universal health coverage very clearly talked about how the private sector could actually be harnessed and work together for public health goals. So that was our second thing. The third thing was we need to be aware that not all women can come to hospitals. It's a reality, I mean, even today, out of those 25 million, about 8 million are still giving birth at home with absolutely no support. So what is it that we can do to ensure they don't all die? How can we link them up? If something goes wrong, how can they very quickly link up to a referral unit? How can we ensure that at least in those areas there are skilled, birth attendants who can actually provide services in the village or in the local health sub-center? We have to think about home births. We cannot pretend, that they don't exist. We've done that for 10 years with disastrous consequences. And the fourth point that we are trying to make in order to improve the system is to think very, very seriously about accountability. And I think one of you had this question as well, is that what did you think about accountability? I mean, what are you suggesting? The way we look at it in the human rights framework, accountability has 4 dimensions. There must be monitoring. And it's not just enough to have large national surveys that come out once every 5 or 7 years. That's not monitoring. There has to be monitoring which is happening locally. There has to be community engagement in the monitoring. Community feedback, user feedback has to be taken in the monitoring so that there is a sense of immediate answerability at the front lines, which is completely missing. Monitoring has to happen. There has to be review. Somebody who did not do the monitoring should review the findings. Unfortunately, the health department generates its own data and looks at its own data. There's complete conflict of interest there. You're fudging everything just to make yourself look good, That makes no sense whatsoever. There has to be independent review. For example, having elected representatives on hospital committees, who actually look at maternal death reports and ask questions, that kind of thing. Or for instance, parliamentarians, they actually do departmental oversight. There are these standing committees which independently review, the budgets and the programs and also the problems that happen within the health department. So independent review, that's the second part of accountability. The third part is very, very important, and that's called remedy and redress. You keep on and on and on monitoring, and you never solve the problems. As I said, in this district in Jharkhand, they've been doing maternal death reviews for 5 years. They know women are dying because of lack of blood transfusions. They still do not have a blood transfusion facility in that district hospital. So do you think remedy and redress has been provided? All those women who lost their lives, what is the point? The health system learned nothing, took no corrective action. So the third important part of accountability is that there must be remedy, that the person who suffered must feel a sense of justice, and there must be redress. You have to do a course correction. You have to improve what you were doing. You can't just go on with business as usual. So these are 3 critical parts of accountability, and we are advocating in this kind of 4 thing: equity, private sector, home births, and accountability. There has to be meaningful accountability for women losing their lives. There was a question about infant mortality. I know nothing about infants, except for the one that I brought up. But I do believe that the appalling state of maternal care services is responsible for a lot of neonatal deaths and stillbirths. And a lot of the data there is being fudged. Babies are dying after they are born, but they are being shown as stillbirths. But they are dying because the labor was completely mismanaged. The baby doesn't survive at the end of it, Like this story I told you about the Dalit woman who was pushed out of the gate and had the childbirth on the street, and the baby died. Obviously, the baby died. So that, I think, needs to be examined very carefully. There's some interesting findings from the Ekjut work, which is, looking at this as well. So I feel that we need to see it in a continuum. you know, that the infant's survival and well-being is linked to maternal survival and well-being. And unfortunately, the health system actually privileges children and children's immunization a lot more than ensuring skilled care to mothers. The final bit about the Latin American countries and Progressa, for instance. I think Mexico, when it started demand-side financing, actually had a functioning health system in place. The thing about decontextualizing global health knowledge, you know, you take it out of Mexico, you put it into Uttar Pradesh. You have the DLHS data, for goodness sake. It tells you you don't have a health system. You have to focus on the health system. You don't have to focus on getting people to the health system. They will come if the health system works. So it is a question of context, not understanding the context. And we have some recent work going on in Mexico, and it's very interesting. With all this demand-side financing and so much other stuff that's happened there, the health system is fragmented completely into different groups of actors that provide health coverage or not, etc. And there is no sense of accountability. There was a hospital in Jalisco that had 24 maternal deaths, and the maternal death data could not be obtained by hook or by crook. It's complete cover-up. You know, so these kind of demand-side financing mechanisms also mean that there is no state accountability, which is what I was trying to explain. The state erases the language of rights when it says your entitlement is just the money. Your entitlement is not health or quality health care. It's just the money that I'm responsible for giving you, only if you follow my instructions. So, you know, the rights language in that particular example for us is becoming very interesting, because there is complete cover-up happening why those women died. It's a district hospital in Jalisco, is not Oaxaca. It is one of the better districts of Mexico, the better states of Mexico, but that's what has happened. So, you know, it's quite complex, I mean, where we take what example and what is happening in those places. Finally, I think what you were saying, Bina, about fixing some of the problems, and, you know, the suggestion about task shifting, you know, getting nurses, for instance, to do these. I completely agree that nurses need to be far more skilled and far more empowered, but they also need to be far more recognized and respected. Because the whole A&M Andolan and the nursing Andolan that is happening nowadays is about the fact that nurses are also treated very badly. They are the kamzor kadi, you know, the lowest, and they are treated very badly, and they treat the ashas even more badly. But that, I feel that just giving them a few skills and then they go into their health center and the doctor says, of course not, you cannot do this, you're a nurse, you know, and dismisses them and treats them badly, and they have bad working conditions. I think if we really want to use the nurses the way that you are saying, it's a fantastic way forward. Africa has done it. We could do it. You know, Tanzania, they're doing C-sections. We could do it, but we need to, I think, revamp the way we look at nurses or paramedical staff in general. I think, I mean, the HLEG report again made a lot of recommendations, you know, in the context of universal health coverage about how to handle this whole, you know, workforce crisis. And one of our favorite models is what we call the hub and spoke. You have a hub, probably a CHC, where the specialists stay, and they stay together. So they have a sense of, you know, there's a collegiate thing. It's not that I'm posted in the back of beyond all by myself, there's nobody with me, not like that. You're all staying together. And there are spokes which go out into the peripheral health centers, you know. And there are rotating duties where the doctors do go to the peripheral health centers, they do provide the services, but they can come back, you know, and they can also, because they come and go on a daily basis, transportation of emergency cases back for critical care is also ensured, you know. So we need to look at new models of handling emergency obstetric care, because, well, a nurse finally will not be able to provide emergency obstetric care. I mean, like this thing about blood. You cannot have a blood in a sub-center. Obviously, you have to bring that person there. So we have to think of new models, how to reach out to these areas. But then, in an urban slum, that's not the problem. That's not the problem. The problem is something else, you know. It's not that the doctors are not willing to stay. It's many, many other issues, social issues, why the poor don't get the services, why the public health system does not function. Okay, I think I have addressed everybody's questions, have I? Anybody feels that I didn't address your question? What was your question? Oh, the MDG one? Oh, I'm sorry. Why did the MDGs erase the language of rights? As I said, feminists have analyzed that it's because of the increasing influence of the international financial institutions, which are called the Bretton Woods institutions, like the World Bank and the International Monetary Fund and so on, which had increasing influence over the 80s and very strongly in the 90s. So Alma Ata was this ideal which was never ever attained, because immediately after Alma Ata, the 80s happened, neoliberalization and everything happened. So there has been a very strong counter current which is actually eroding that whole rights-based framework of primary health care, women's rights, etc. And the MDGs, they were actually not what everybody made them out to be. MDGs were actually development goals also for international development assistance for these big donors. It was supposed to give them also guidance on what they must attain in 15 years. Unfortunately, they got translated into a national target, which was actually not the point. And they, like across countries, they became like the same numbers and all, ridiculous. So MDGs were meant to be something else, they became something else, but they are also the culmination of a process that started in the 90s, which has gradually worn down the language of rights. And there is a whole different discourse around the rights to sexual health and reproductive rights like abortion. There's a huge global opposition to that, and ground has been lost after 1995. We are actually behind now in where we are. And the international human rights institutions and mechanisms like the Human Rights Council, the treaty bodies like the CEDAW mechanism and the Universal Periodic Review mechanism and all, the health and development planning is not talking to those human rights mechanisms. So countries wahan jate hain, they give one report, they come back. When they go here where the money is coming, something else is being asked for, something else is being told, something else is being given, There are two different things that are happening. They don't talk to each other. Okay, thank you.
While others might be thinking what question, I'm very tempted to ask this question, if I am allowed to. This is a larger question which bothers me, during your so many years of experience of policy advocacy, that's the privilege that you have had, what is the scope that you see to actually incorporate in its true sense of the term the language of rights, not in terms of just kind of pretending to be in terms of rhetoric, but actually in terms of practice into policy. So can we really have a successful policy which talks about rights? And this I am saying it from a kind of an anecdotal evidence from a health minister, I think I've shared it in other forums, who says that, who was listening to many of our sessions where we are talking about exactly like this, and he reacted, what does human right mean? So we said, okay, this is what it is. You said, no rights, no patient's rights, galata ho jayega. Galata in Kannada language is basically, fighting. So, that we can't give. So because I think somewhere the whole threat of many very empowered citizens who actually demand services, etc., is a threat to the state. The state under any given circumstances would like to have compliant citizens by giving more material incentives. So I've heard many of these, in the state level, people say, yes, NRHM is a right-based kind of this thing. And what does that mean? That means is that they have access to actually this, whatever 1400, 700 gas sensitive. That's right-based. So, yeah. Is that the last question? Free to ask. Yeah, anybody else? I think you are getting on to time also. 3:30 hone wala.
Okay, so the last and final question, the language of rights. Let me deviate. Let's not talk about health. Let's talk about other rights. And one of the things that I've been noticing that in the last decade in India, we've had very large number of rights-based movements leading into rights-based legislation, leading into rights-based programs and budgets. Anybody give me an example? RTE, anything else? Food security, anything else? Manrega, anything else? What about RTI? The mother of them all. Okay, yeah. But yeah, I mean, these are just a few, but there are others. There is the Forest Rights Act, which is very, very important for especially forest dwelling and tribal communities. There is other acts around domestic violence and so on, of course, right to education and many others. So it's interesting that the last 10 years, which had very strong neoliberal policies as well, also saw this creation of the safety nets, so to speak, in terms of providing a kind of buttressing with the language of rights. The Food Security Act, I'm afraid, has not actually yet translated into rights. But I think the Manrega, and if there are anybody in this room who is working on livelihoods, they might be able to comment more upon it. But the Manrega did put in place a framework which was fairly rights-based in terms of, ensuring that there is a legal provision. It began as a scheme and then became an act. So there's a legal provision for what the state is meant to give the citizen. There are forums for the citizen to have grievance redress. If the state fails to provide that entitlement, there is a compensatory, that non-working allowance kind of thing, which the citizen can claim. There is a language of gender equality. There is affirmative action for pregnant women, disabled women, older women, women with any other physical problem, etc. So it was trying to, and of course there is all this creche and all these other things. Of course, it doesn't have maternity entitlements, but I'm saying, so that is an example. And if you've studied Andhra Pradesh, that social audit mechanism that they've been trying to use, in which they try and see whether actually communities can also participate in the monitoring of how this law has been implemented. So I'm not saying that everything was covered, but it gives an example of rights-based legislation. Right to education is a bit problematic because of its kind of ambivalence about the role of the private sector. And I think there, many of us have questions about whether or not it did the right thing. But definitely, for instance, the Right to Information Act, which was a very seminal and kind of basic first-generation rights act for our country, it really strongly brought in the language of the citizen as a rights holder and the state as the duty bearer. No, so if we were going to look at health, actually, what would happen would be, we would need first a legal entitlement. NRHM put many things in place. They had these concrete service guarantees, they had patients' rights charters, every state had to put these up everywhere, etc. They had community-based monitoring, decentralized budgeting, planning, review. I mean, it kind of put in the mechanisms, but it did not go as far as actually having a national health law. I'm sure many of you know that there was a law which was debated about 5-6 years ago, but then of course beech mein hi, there was a lot of debate, and then the private sector was the elephant in the room there again. People couldn't figure out whether they should go the RTE kind of route or take a different route. Should they be pragmatic? Should they be idealistic? So kind of never got figured out. Now that has got watered down. There is a public health policy draft, and then also a bill which is floating around, but nobody's actually giving it. The Clinical Establishment Act was meant to regulate the private sector, but everybody's terrified of regulating the private sector. So it's not moved ahead at all. So there are these various kind of situations with regard to putting in rights-based legislation. It's not that India has never done it, or that India is incapable, or India does not have the enabling environment, which is a robust civil society, a vibrant media, freedom of speech, constitutional guarantees, right to information. We do have the enabling elements which could make for a rights-based approach. But I think it needs much more public pressure and much more, insistence before the policymakers will actually recognize it for that. So I think we should close. Thank you very much for your wonderful questions and your attention.